of Mount Sinai Medical Center is here with us. I don't think my poor co-host is with you at your hospital. But
well, even if I knew, I couldn't tell you.
The HIPAA laws, right? You're here to talk about, you've got this new partnership, is it? Is that correct, with GE Healthcare? Or
conducting a great experiment with General Electric. We're working on a one-of-a-kind project with them where we will begin to track the movement of patients, supplies, equipment to the medical center. They've done bits and pieces of this at other hospitals around the world before, but this is the first time really that they brought the technology together with their rocket scientists up in their research center to create a whole new model for managing patient flow. And it's critically important for hospitals in the Northeast and hospitals like Mount Sinai in New York.
But Mount Sinai is a very successful hospital. You move a lot of people. What is it that you hope to gain from all this?
Well, I think that you know, one of the things that you realize in New York, we're a little different than other parts of the country. We're a little different in the sense that we operate at very high levels of occupancy. It's pretty commonplace for hospitals in New York to run at 85 to 90% occupancy, meaning most of our beds are full most of the time. And that's during normal conditions. That's not during flu season or some other extraordinary event. Around the country, hospitals typically operate at occupancy levels much lower than that. But we would believe that with the changes in health reform, insurance reform and the like, that the operating margin for these hospitals is going to be under considerable pressure. So they too are going to look for ways to better use their capacity.
We were going to have 32 million people coming online, potentially. They're not going to go to the hospital, but you got to imagine some of them are going to wind up in the hospital.
Sure, there's going to be a lot of new demand, absolutely, and it will affect the rest of the country the way we think. In New York, we've been kind of leaders in this regard, dealing with high levels of occupancy. We are successful, but one of the ways that we remain that way is to be able to manage patient flow, clinical outcome, patient safety in a very crowded environment. I think the best analogy I can use for you is the airline industry. If you look back, let's say 10 years ago, the average capacity occupancy on an airplane was something like 50 or 60%. Post-deregulation, when the airline industry became much more competitive, you saw levels of occupancy at 85, 86, 90%, which is about where it is today. Now, airlines have figured out, putting aside lost baggage, passenger complaints, getting stuck on the runways, and all the things we hear about, airlines, in fact, have been able to figure out ways to manage those levels of occupancy demand fairly successfully. And, of course, now the FAA has just announced a whole new generation of ways in which to make that even more efficient with landing slots and control of planes as they approach final approach.
But Wayne, I got to pay for my blanket on the plane. I mean, it's not going to get to that.
And the airlines don't make any money.
Right, and there's that.
No, well,
we're
that's
not going to
fuel,
get to that point with the hospitals, are we? Or is it going to be tight with these new rules?
Well, it's always, I think, healthcare operates at a very thin operating margin. With all the talk about the rise in healthcare costs and the expense associated with healthcare, the reality is for most hospitals in most parts of the country, even those that are considered the most successful, they operate with very thin operating margins. So, in fact, we have to be even more efficient and more effective in managing our capacity than ever before, and that's not going to change.
But isn't just the fact, for instance, one of the people writing in actually pointed out with the airlines, the reason they're perhaps being more efficient is they've removed planes from the system, so that, you know, you've got more people or the same amount of people flying on fewer jets. Same kind of thing's going to happen with hospitals. St. Vincent's here in New York City is closing. Those people are going to have to go somewhere. And what I'm curious, what GE Healthcare is doing is, what do? If you check into the hospital, you know, under this program, do they put something in you or on you that's like a homing device that electronically monitors everything that happens to you?
Well, no, it monitors your location. So we know, for example, that if we have patients who are scheduled to go to radiology for a diagnostic test, they're inpatients. This allows us to know in sort of a control board where these patients are at that moment in time. Are they in their room waiting to be transported? Are they en route? In fact, are they waiting in radiology for the procedure to begin? Now, the reason this is important is not because we can't find any individual patient at any point in time. We do that. All good hospitals do. It's so that we can constantly model and project demand and capacity at key points in the clinical process during the day. There are some unexpected consequences, by the way, of this technology, I think, and that is that being able to account for all of your patients all at once is useful in the event of a mass casualty event, in the event of some sort of an internal or external disaster. So there are a bunch of other collateral benefits to it, but fundamentally it's designed to allow us to make projections and predictions around demand for service at any moment in time, in that week and moving forward in time. Let me give you a perfect example. And to go back to the airlines, it's not a perfect analogy, but I think it's pretty close. If American Airlines decides today that they're going to begin service flights between New York and London, new flight, new time, new schedule, they don't wait until they've sold all the tickets, filled the plane and taken off from JFK to figure out whether they have a landing slot, they have sufficient capacity in the terminal, or they have enough baggage handlers on the other end to be able to unload that plane and satisfy their customers. They've planned all that in advance. We recruit physicians all the time. St. Vincent's, a hospital struggling and will close shortly. When that happens, that places unexpected new demand on the system. Now, we're pretty good at it. We sit down with, fairly sophisticated projections, but the fact is we don't have benefit of the kind of sophisticated technology and modeling systems that this GE program will bring to bear on us. GE does this already for lots of other components of their business. What they're doing is applying this technology and this intelligence to healthcare and the flow of patients and devices.
Is it bad that the first thing I thought of is, man, how cool would it be if I put a chip in my kid and I could follow them around and know exactly where they are?
But I'm curious, so the system, it's not just following the patient, but I guess the system has some kind of algorithm or something that tells you, the administrator, okay, we're going to have a surge of people who need x-rays over in this portion of the hospital. Is that the kind of thing we're talking about?
Yeah, sort of. I think that it's easy to get sort of hung up on what sounds like the razzle-dazzle part of the project, and that is the RFID device, radio frequency identification device.
Yeah, it doesn't empty bedpans,
that the patient has on their ID band. All right, so that's not new technology. That's been around for a long time, and there's nothing all that special about it. They've made some improvements in it. The devices themselves cost about $20, so now it's kind of affordable that you can distribute them to patients and expect a loss rate of a certain amount. The other technical breakthrough is room and bed level location. So we now not only know that Wayne, the patient, is on this particular nursing unit, we know that Wayne's in his bed as opposed to in the hall as opposed to in a treatment room. So that level of specificity is actually sort of a breakthrough.
And it must help with wait times, too, to and from, and making yourself more effective.
So to go back to your question, here's the real breakthrough. This is what makes this worth pursuing. It's the intelligent devices and the modeling that's behind this now. So we've always had systems for managing the OR schedule. We've always had systems for managing patient transport, and like every other hospital, we've always had systems for keeping track of which patient's in which bed and who's waiting for a bed in the emergency room. What this does is bring all those sources of information, all those data feeds together in one central master modeling board that will allow us to know at that moment in time who's where, waiting for what bottlenecks are beginning to occur, and how we can best manage those. But most importantly, not only does it help us manage this moment to moment and day to day, it allows us to make predictions. So today feels like a typical day in April with respect to the number of patients that are waiting for beds, the number in the emergency room, and so forth. But if we were to model the effect of, say, the closure of a local hospital, model the effect of our successful recruitment of a new surgeon, model the effect of, well, geez, what if H1N1 reappears in the fall? What will the demand look like then? It allows us to do things that are fairly common in other industries, sophisticated industries, but not at all common in healthcare.
So, and are they doing this at other hospitals, or just you guys now? This is the test?
We're an alpha site. We're developing it together. We're partners in building this program. I think GE has some pretty ambitious expectations about being able to roll this out globally. They think, for example, that although only about 5% of the hospitals in the country have the kinds of occupancy levels that you have in New York, they believe the market more broadly are those hospitals that operate at 50% occupancy, but will, through health reform, insurance reform, really, and ongoing economic pressures, have to find ways to manage, as the airlines did, with fewer planes, fewer beds, less space, fewer nursing units, and, in fact, more efficient use of staff.
How does this whole reform, how did you find the whole reform that was passed? Is it going to be a positive for you? Is it a negative? How does the hospital industry view this right now?
Well, I think that that's probably difficult to answer because I suspect that people across the country view it in different ways. For academic medical centers, particularly those in New York, particularly those in New York State, where we have fairly generous Medicaid coverage today, it's probably more of a threat than a benefit. There are some things in there that provide interesting incentives for us, some opportunities to do some new and interesting things like the so-called innovation zones. But other aspects of it actually are just frankly economically threatening. The reduction in so-called disproportionate share payments, where through Medicare and Medicaid payments we receive a certain amount of money today for patients who are in fact uninsured. There aren't as many uninsured patients who don't qualify for Medicaid in New York as elsewhere. So that's going to be sort of a direct economic hit.
And are you modeling, I'm curious, because we have to have it was within 90 days of the president signing the legislation, the pools set up, the insurance pools for the high-risk folk. That we're closer to that now than we were when he signed the bill. Are you guys expecting a surge of people who, because they are high risk, they're not in as good a health as other people?
No, I think what happens in New York a lot, we turn nobody away. So patients like that typically wind up in emergency rooms in New York City hospitals, and they wind up getting care. It may not be the care that you or I would want in terms of emphasis on prevention and access to a primary care doctor early on and so forth. But they're not turned away. They get care. So I don't think that, we're not expecting this big rush of demand on the inpatient side. Where we're going to see the crunch, I think, is that with the ongoing emphasis on primary care and prevention, we're going to see a demand for primary care physicians that can't be met.
Right.
They're not out there.
No.
And it will take quite some time, frankly, for the educational process to turn them loose.
Wayne, you got to come back and tell us how the project is working.
I will.
Especially those who want to buy GE stock, right?
That too.
I think it sounds
Is it $18 a share? Maybe not too late? Right. I think it's very promising. We're looking forward to it.
Wayne Keithley, president of Mount Sinai Medical Center, right up the street. Thank you so much for
My pleasure.
Thanks for being here.
My pleasure.
I think
Thanks,
that's really interesting, and I do think that maybe they should make a product for children. We could just follow them all over the what do you call it?
It's called a leash.
Playground.